Greetings, my dear students. I am Mona Talab. I'm Associate Professor of Clinical Hematology, and our seminar for today is Clinical Practice Guide on Blood Component Transfusion. These are our intended learning outcomes that will be discussed through our seminar today. First, red blood cell as therapeutic product. Proper uses of red blood cell transfusion. Red blood cell transfusion is used for treatment of symptomatic anemia, prophylaxis and life-threatening anemia, restoration of oxygen carrying capacity in case of hemorrhage, and also red blood cell indicated for exchange transfusion in cases of sickle cell disease, severe parasitic infestation, for example malaria, severe methemoglobinemia, and severe hyperbilirubinemia of newborn. Red blood cell transfusion is not routinely indicated for pharmacologically treatable anemia, such as iron deficiency anemia, vitamin B12, or folate deficiency anemia. Dosage and administration. 1 unit of red blood cell will increase the hemoglobin about 1 gram per deciliter. EPO and RH groups of red blood cell products must be compatible with EPO and RH groups of the recipient. Exceptions can be made in emergencies. The standard rate of transfusion is that transfusion should be slowly for the first 15 minutes and complete the transfusion within 4 hours. Major red blood cell product for transfusion. Most red blood cell products are derived by collection of 450 to 500 milli of whole blood from volunteer donors and removal of the plasma by centrifugation. After removal of plasma and platelets, the resulting product is red blood cells, referred to informally as packed red blood cells. The most commonly available red blood cell product has a 42-day blood bank shelf life. Pre-transfusion testing. Pre-transfusion testing prevents incompatible red blood cell transfusion, compatibility of donor red cells and recipient plasma. Pre-transfusion testing is also done to avoid immune hemolytic transfusion reaction in the recipient. Pre-transfusion blood sample from the intended recipient, usually edit a tube, and proper labeling of the sample. 2 independent patient identifiers. We also have to identify the phlebotomist, date and time of the sample collection, and sample rejected without these issues. These are the blood donor selection criteria. First, well-being. The donor should be in good health, mentally alert, and physically fit. Regarding the age of the donor should be between 18 years old and 65 years old. First-time donor should not be over 60 years of age, and for repeat donor, the upper limit is 65 years old. For whole blood volume collected and weight of the donor, for donors 45 kilos, the amount of blood volume should be 350 milli, and for donors more than 55 kilos, the blood volume collected should be around 450 milli. Regarding donation interval, for whole blood donation, once in 3 months in males and 4 months for females. For the blood pressure, the systolic blood pressure should be between 100 and 140 millimeter mercury, and the systolic blood pressure should be within 60 to 90 millimeter mercury with or without medications. There should be no findings suggestive of end organ damage or secondary complications, for example cardiac, renal, eye, vascular, or history of feeling giddiness, fainting made out during history and examination. Neither the drug nor its dosage should be altered in the last 28 days. The pulse should be regular between 60 and 100 per minute. The donor should be afebrile. The donor should be free from acute respiratory disease. And lastly, the hemoglobin level should be 12.5 or more gram per deciliter. These are red blood cell transfusion recommendations for hospitalized hemodynamically stable patients in specific clinical situations. For example, in ICU patients, we should transfuse if the hemoglobin level less than 7 gram per dl. In post-operative patients and cardiovascular patients, we should transfuse red blood cell when the hemoglobin less than 8 gram per deciliter. Regarding acute coronary syndrome, there is no guidelines recommend for or against liberal or restrictive red blood cell transfusion strategy. And for all other patients, the transfusion should be guided by symptoms as well as hemoglobin level. Adverse effects of transfusion. The most clinically important adverse effects of transfusion in medical patients are infectious or immunological phenomena. The most significant infectious risks are addressed during donor screening process, and most blood centers employ bacteriological surveillance measures on certain blood products. These are the most common transfusion transmitted infection during blood transfusion. For example, HIV, hepatitis C and B virus, cytomegalovirus, bacterial infection, and less commonly West Nile virus and parasitic disease, for example, toxoplasma, Chagas, and malaria, which are considered relatively uncommon. Other important adverse effects of blood transfusion: in these cases, we have to stop the transfusion and return remaining blood products to the blood bank with transfusion reaction report, with some exception, for example, allergic or urticaria reaction. First, we have febrile non-hemolytic transfusion reaction, which occur in about 0.1 to 1% of cases due to performed anti-white blood cell antibodies in the recipient. Risk minimized with leukocyte reduced products. There will be more than or 1 degree centigrade rise in the temperature within 2 hours of start of transfusion with no other explanation of fever, and usually managed by acetaminophen pre-medication if reactions are recurrent. We have allergic or urticaria reaction occur in 1 to 3% of cases, occur due to antibody to donor plasma proteins. Patient presents with urticaria, pruritus, flushing, mild wheezes. In this case, we have to stop the transfusion, give antihistaminic, and we can resume transfusion if reaction resolve. However, we have to report reaction to the blood bank. Anaphylactoid or anaphylactic reaction, which caused by antibody to donor plasma proteins, IgA, haptoglobin, or complement 4. Patient presents with hypotension, urticaria, bronchospasm, anxiety, or even angioedema. In this case, we have to stop the transfusion, IV colloids to maintain blood pressure and circulatory volume, anti-allergics in the form of antihistaminics and corticosteroid, and in severe cases, I may give epinephrine 0.2 to 0.5 milliliter. Acute hemolytic transfusion reaction. This occurs due to performed antibodies to incompatible products or in APO incompatibility. Patient presents with chills, fever, hypotension, hemoglobinuria, renal failure, and patient may progress to disseminated intravascular coagulation. We manage the case by keep IV open with normal saline, keep urine output more than 1 milli per kg per hour. We can give vasopressor if needed, and sometimes we need to treat DIC. Delayed hemolytic transfusion reaction, which is an amnestic immune response to incompatible red cell antigens. Patients present with fever, jaundice, marked decrease in the hemoglobin with newly developed positive antibody and blood screening. This occurs 1 to 2 weeks after the transfusion, and in this case we may give transfusion with compatible RBCs if needed. Transfusion related acute lung injury. It's typically associated with plasma components such as platelet and fresh frozen plasma. Though cases have been reported with packed red blood cells, since there is some residual plasma in the packed cells. Transfusion-related acute lung injury is uncommon syndrome that's due to presence of leukocyte antibody in transfused plasma. Leukoagglutination and pooling of granulocytes in the recipient lung may occur with the release of the content of the leukocyte granules and resulting injury to cellular component, endothelial surface, and potentially to lung parenchyma. This is the pathogenesis of transfusion-related acute lung injury, which is a two-hit model. The first hit involves neutrophil sequestration and priming in the pulmonary endothelium, which precede the transfusion. Endothelial cells are thought to be responsible for both neutrophil sequestration and the priming. Second hit is caused by activation of the endothelium and neutrophils by mediators in the transfused blood, resulting in capillary leakage and pulmonary edema. This should be suspected and treated first before moving on to factor deficiency as cause of coagulopathy. Clinical picture occur in the form of hypoxia, hypotension, bilateral non-cardiogenic pulmonary edema, transient leukopenia. The figure on the right side reveals normal chest x-ray, and on the left side reveals patient with transfusion-related acute lung injury with bilateral non-cardiogenic pulmonary edema. The onset of this complication occurs within 6 hours of transfusion, and it's 10 to 20% fatal. Usually, this complication managed by supportive care, oxygen therapy, and defer the implicated donors. Transfusion-associated graft versus host disease. It's awful, fatal, and thankfully it's a rare complication of blood transfusion. It's caused by transfusion of viable T cells present in blood products that are not rejected by the transfusion recipient, either because of recipient immune deficiency or because of the common HLA haplotype between donor and recipient. There are 3 recognized risk factors for transfusion-associated GVHD. First, the volume and age of blood transfused, as this determines the number of viable T cells in the transfused component. Secondly, HLA haplotype sharing between donor and recipient. And lastly, depressed immune system of the recipient. Target organs for transfusion-associated GVHD are skin, GIT, liver, and most importantly, the bone marrow. Clinical presentation occur in the form of maculopapular rash, diarrhea, hepatitis, and most importantly, pancytopenia. This complication occurs 1 to 4 weeks after the transfusion and usually prevented by irradiation of the blood products. Massive blood transfusion. Massive blood transfusion is defined as acute administration of more than 1.5 times the patient estimated blood volume, or the replacement of the patient total blood volume by stored blood bank in less than 24 hours. The sequelae of massive blood transfusion are coagulopathy. Coagulopathy is common with massive transfusion. The most common cause of bleeding following large volume transfusion is dilutional thrombocytopenia. Citrate toxicity results when the citrate in the transfused blood begin to bind calcium in the patient's body. Clinically significant hypocalcemia doesn't usually occur unless the rate of transfusion exceeds 1 unit every 5 minutes. Citrate metabolism is primary hepatic, so hepatic disease or dysfunction can cause this effect to be more pronounced. Treatment usually is with intravenous calcium administration, but identification of this problem requires high index of suspicion. Hypothermia. Hypothermia should not occur on regular basis. Massive transfusion is an absolute indication for the warming of all blood and fluid to the body temperature as it is being given. Acid-base balance can be seen after massive transfusion. The most common abnormality is metabolic alkalosis. Patient may initially be acidotic because the blood load itself is acidic, and there may be a prevailing lactic acidosis from hypoperfusion. However, once normal perfusion is restored, any metabolic acidosis resolves, and citrate and lactate are then covered to bicarbonate in the liver. Serum potassium. Serum potassium can rise as the blood is given. The potassium concentration in stored blood increases steadily with time. The amount of potassium is typically less than 4 milliequivalent per unit. So you can see that large amounts of blood at high rate of delivery is required to raise serum levels of potassium. Now we shift to the platelets. Biological aspects of the platelets. Platelet production in adults. The bone marrow produces 2 to 5 million platelets per second to keep the platelet count between 150 to 400,000 per cubic millimeter. Platelets have a strong expression of HLA class 1 antigens with weak expression of APO antigens. These are types of platelet concentrates. First, we have single donor platelets done by apheresis, a single donation using cell separator, and more than 80% of platelets are separated this way. Second type is random donor platelets, separated from the whole blood within 8 hours after donation, pulled from an average 6-unit pool of a whole blood. The third type is HLA-matched platelets used in refractory patients who don't have satisfactory response to a normal platelet transfusion. Dose of platelet concentrates. After a platelet apheresis, unit or 6-unit pool of whole blood derived platelets is considered adult therapeutic dose. Increase of 5,000 to 10,000 platelets is expected for each random donor platelet, and increase of 25,000 to 30,000 platelets for each single donor platelet. Post-transfusion platelet count at 10 to 60 minutes is critical to evaluate the response. APO identical or compatible platelets are preferred but not necessary in adults. But rhesus compatibility is required in recipients who are children and women of childbearing age to prevent hemolytic disease of the newborn. Platelet refractoriness is the repeated failure to obtain satisfactory response to platelet transfusion. A variety of immune and non-immune conditions can account for inadequate platelet response, and usually the reasons are multifactorial. Non-immune causes are the most common. They include splenomegaly, fever, sepsis, disseminated intravascular coagulation, infection, bleeding, graft versus host disease, and medication, for example, vancomycin, sulfonamide, and heparin. Immune cause, specifically human leukocyte antigen HLA antibodies, should be considered after non-immune possibilities are ruled out. This is important tips we have to know. APO-RH compatibility is required. Compatibility testing is not required, but in emergency situations, any APO group can be given. Platelets must be stored between 20 to 24 degrees centigrade on a platelet shaker to ensure viability and prevent aggregation. Allowed extension of the shelf life from 5 to 7 days. Platelets should be infused over 15 to 30 minutes and no longer than 60 minutes. If any gross aggregates are seen, don't transfuse. And lastly, standard blood transfusion sets are adequate for platelet transfusion. When would we transfuse platelets? Platelet transfusion may be required in the event of hemorrhage as prophylaxis or pre-procedure. When prophylactic transfusion is considered necessary, a post-transfusion count should be obtained to assure appropriate increment before performance of the procedure. As with all transfusion, the risk and the benefit should be carefully considered. The following are general guidelines to identify when a platelet transfusion is indicated. But please note, specialist hematology advice should be sought for patients with platelet function disorder, platelet consumption, for example, disseminated intravascular coagulation or immune thrombocytopenia. For patients with hemorrhage, the aim of platelet count is more than 75,000 per cubic milliliter. In multiple trauma, eye or central nervous system injury, we have to keep the platelet count more than 100,000 per cubic millimeter. For prophylaxis, we should keep the platelet count more than 10,000, or we can transfuse platelet if the platelet count less than 10,000, or transfuse platelet if the platelet count less than 20,000 in presence of additional risk factors for bleeding, for example, sepsis or fever. These are pre-procedure target platelet counts which should be maintained before surgery. However, I have to say that these cut-off levels depend on the expert opinion and there is no formal study. Platelet refractoriness is the repeated failure to obtain satisfactory response to platelet transfusion. A variety of immune and non-immune conditions can account for inadequate platelet response, and usually the reasons are multifactorial. Non-immune causes are the most common. They include splenomegaly, fever, sepsis, disseminated intravascular coagulation, infection, bleeding, graft versus host disease, and medication, for example, vancomycin, sulfonamide, and heparin. Immune cause, specifically human leukocyte antigen HLA antibodies, should be considered after non. Now we go for fresh frozen plasma. Fresh frozen plasma consists of fluid portion of blood that is separated and placed at minus 18 degrees centigrade or below for 1 year approximately. Fresh frozen plasma is labeled with donor EPO and RH group. We have to give EPO compatible fresh frozen plasma, but compatibility testing is not required. Volume of typical unit is 200 milli, and the dose of fresh frozen plasma is 12 to 15 milli per kg at a rate of 200 milli per hour. Thawed plasma should be given within maximum 2 hours to avoid the loss of potency of coagulation factors. These are indications of fresh frozen plasma. Fresh frozen plasma is given to replace single coagulation factor deficiency where specific or combined factor concentrates are available. Also indicated for severe traumatic or surgical bleeding with large packed red cell requirement. Immediate reversal of warfarin, which is one of the oral anticoagulant, in patients needing emergency surgery, and we can't wait 12 hours for vitamin K to become effective. Frozen plasma is also indicated in DIC with hemorrhage or abnormality of coagulation test. Fresh frozen plasma is also indicated for plasma exchange or plasmapheresis in a type of microangiopathic hemolytic anemia called thrombotic thrombocytopenic purpura. And lastly, fresh frozen plasma may be given in patients with liver disease with prolonged prothrombin time. When would we transfuse platelets? Platelet transfusion may be required in the event of hemorrhage as prophylaxis or pre-procedure. When prophylactic transfusion is considered necessary, a post-transfusion count should be obtained to assure appropriate increment before performance of the procedure. As with all transfusion, the risk and the benefit should be carefully considered. The following are general guidelines to identify when a platelet transfusion is indicated. But please note, specialist hematology advice should be sought for patients with platelet function disorder, platelet consumption, for example, disseminated intravascular coagulation or immune thrombocytopenia. Granulocyte transfusion. Granulocytes collected by apheresis are rarely indicated or used because of the availability of what's called the granulocyte colony stimulating factor or granulocyte macrophage colony stimulating factor. Because these products contain lymphocytes that can cause graft versus host disease, they are typically irradiated. Granulocytes must be transfused as soon as possible after collection, as the function deteriorates rapidly with the storage. Indications for granulocyte transfusion include patients with severe neutropenia and infection who don't respond to antibiotic treatment. This reference I inserted that would help, and this is my email. Please send me your inquiries or if you have any questions, and please keep me posted if you need anything. I hope the seminar is useful and satisfactory, and thank you so much for listening, and have a nice day. Thank you.